Well, thank you for joining us for another episode of Optimized Health. Hello, Miss Laura.
Hey, Mandy, how are you?
I'm good. I'm good.
Staying dry out there?
No.
The monsoon?
This is not the weather of my people. And by that, I mean curly-headed people.
Well, I thought it, like, rain helped curly hair. No.
Rain
My daughter
makes-
is super curly, and the rain is her friend. It makes it really just bouncy and more
She's
curly.
She's got those super
She
tight
does.
curls.
Yes.
I have that frizzy curl. So
I got
rain
you. That's
is
kind of
not
like
of my
mine.
people.
Yeah, not mine either. So the fact that we video this now is a little bit unnerving for me, but that's okay.
I know.
Life will go on,
I know,
right?
right?
First world problem.
Right. Exactly. So how's your month been so far? We're in February now.
We are February 10th today for this recording, or 11th. No,
11th.
Today's the 11th. It's going well. It's going fast.
I didn't know you were going to test me today.
I know, right? It's going fast. I can't believe we're 6 weeks into the new year.
Oh.
All those New Year's resolutions / intentions are starting to be tested.
Yeah, right.
You know, so trying to step back and reevaluate all the things
What's that
I set out.
consistency look like?
I set out to do. So trying to work on that. What about you?
I'm doing good. I had a revelation, like I guess yesterday maybe.
Okay.
That Valentine's Day is this week, and I was
It
like,
is.
oh crap.
I know. I know. I used to have so much fun making those boxes with my kids, though.
Yeah.
I mean, you know, it was.
I don't have any of that now.
Well, we don't really either, you know, teenagers. So, you know, bag of Hershey Kisses and move on kind of thing.
I know, right?
Or a gift
though.
card.
So he's my only one hanging out is Robbie.
Yeah.
Like he's the only one. My husband's the only one hanging out. And I'm like, I literally looked at him last night and I went, so tag you're it this year. Where are we going for dinner?
I said, you know what? I just would like to stay in. That is kind of my ideal Valentine's. I just like to be low
Chill
key.
out.
Yeah, I do. Friday night, you know, put on a good movie kind of thing. So I don't think we'll have any big plans for Valentine's.
Listen, we're probably getting a little too old for it.
Yeah,
anyway.
true.
Hallmark
that.
has maxed out on us.
Yeah, it has. Every day's Valentine's, right?
That's right.
Okay, sure. Yeah. I'll leave your outlook on that. Absolutely.
I'll take roses every day.
Right.
Yeah.
Well, we've got a guest in the studio today.
We do.
It is going along with what we decided to do this year as a team was to come up with, okay, we would like to give just a really good series to our listeners. And who better to go to for said series than our friends at Nurrition World?
Yes,
I mean,
absolutely.
Let's just call it like we see it.
I know.
So
we go to them for all kinds of things, right?
it's not a lie.
Yeah.
So as a part of that, we decided to do a series with the experts from Nurrition World. So Laura, you want to introduce our guest?
I will. We have Curt Dearing with us today. He is one of the newer members to the Nurrition World team and definitely has a unique role there that we are super excited to highlight today. So Curt, welcome to Optimized Health.
Well, thank you. Thank you for having me.
Yes, thank you for coming. And I'll just let you tell a little bit about your history, your certifications or specialization, and then how you came to the role that you're in now.
Yeah. Well, I went to pharmacy school in Atlanta at Mercer University. And my first job was at Grady Health System in Atlanta, and I established ambulatory care, pharmaceutical care services there. And what we're going to be talking a little bit about today is hypertension, high blood pressure, and that's one of the first clinics I ever started was a hypertension clinic. I used to send people home on 24-hour blood pressure monitors. That was kind of cool back in the day.
Yeah.
And see how they do when they get away from the office and how they do while they sleep. Anyway, it was cool. But then I started, one of my first guidelines I ever did was on high blood pressure. And this is the kind of patient that should be using this kind of blood pressure medication would be ideal for them. And so teaching residents, I've always worked in a teaching institution with the medical schools. So at this point, it was medical students out of Morehouse and out of Emory, and they were doing the residencies down there. And then, anyway, I did that for about 7 years. Then I came back to Chattanooga, which is my hometown, and I started working at Erlanger. I worked there for 25 years. Same thing. I worked at the University Medical Associates, where the residents get trained. So most of the doctors in town I've worked with in some way, or helped quote train them. I was there for any kind of pharmaceutical education or anything they wanted to know. So then I started running diabetes clinics, and I'd say it was a combination of a few things that led me to open my eyes a little bit more about is the pharmaceutical option always the best option. It's always it's good for a Band-Aid sometimes. Sometimes it's good to solve a problem. But in the kind of disease states I was working in, which are long-term health conditions like diabetes and hypertension and dyslipidemia, these kind of conditions are really the result of lifestyle and what you've done to yourself and toxicities you've put in your body. So the answer is not just to continue to put a Band-Aid on it with more and more medication. The key is to go and find the root cause of the problem and eliminate it. And it took me maybe too long to figure that out, because I thought I was doing great running a diabetes clinic. And, I would get these patients' A1C numbers down a few points with whatever medication I happened to put them on, and feeling really good about it. But then all of a sudden, they drop a point or so, and then they come back and it's slowly creeping back up. And I'm like, okay, well, we're going to up your dose on that, and then they come back and like, well, we upped your dose to the max, so let's start this new medication on. And you're doing the same thing. And so it took me a while to figure out this just is and when in the diabetes world, they call it a progressive disease. It's almost like they've given up on the fact that you can actually cure it or minimize it or reverse it. And so it was just the thought was, this is a progressive disease, and you're just going to continue to have to do more and more. And then in my own life, I changed. I was putting on more weight and having more brain fog and more just not feeling good. And so I changed. My sister and brother-in-law, my sister went off of her blood pressure medication because of the way she changed her diet. She went on a plant-based diet. Okay. So she went completely, plant-based, and based on that, she dropped about 30 pounds or so, which is the best way to drop your blood pressure, is to lose weight and eat healthy and exercise. And that's exactly what she did. So I saw what she was doing, so I embraced that lifestyle for several years. I ended up coming up to now I do more of a paleo type diet, where it's grass-fed beef and organic, only organic, mostly vegetables and fruits and those kind of things. But it's because I believe in that can work too. But the plant-based diet was what kicked me off to the healthy lifestyle. And I started thinking, this worked for me. Surely this will work for my patients. And so I was a little hesitant, because the clinic I worked at was the working poor. And so I don't know whether I wasn't giving them enough credit, but when I started working with them and I'm sitting down taking time, and that's the problem, is that most physicians they've got 15 minutes to take care of everything.
Right.
So my diabetes clinic, I could sit down and spend sometimes up to an hour just with one patient. So that's the first thing I did. I started saying, look, we want to change this. We got to get rid of the toxicity. We got to stop putting the high fructose corn syrup in your drinks. You got to get rid of the colas. You got to get rid of the bad meat. You got to get rid of this processed oils. So, bam. We're literally from the first several patients that I did it on, it was like a miracle. All of a sudden, these guys were dropping 4 points in their A1Cs.
Wow. And
coming off of medications. And so that's when it's kind of embarrassing that it took something like that to realize that's what works. But I think you get indoctrinated into a certain way of thinking in the medical field that you don't even think outside the box anymore.
Yep.
And what really drove me to the newest, drove me over was when my mom started to have cognitive dysfunction. And when she was about 85, 86, she was just, we were starting to see some slipping there. And I said, no. And so I looked in. That's not my specialty area, but I looked into it and got a friend in Atlanta that's a neurologist, and there's no answers. There was nothing out there.
Like it just is what it is.
Yeah. And so I came across some information that talked about all these different nutraceuticals that you could use. And I started on about 7, 8 different things, and she just turned around just like that. It was amazing.
Wow.
Now, at some point, many years later, about 5 years later, she had a colonoscopy, went under anesthesia. She came out of the anesthesia a little bit confused, but she had done that before. She had a migraine, took some medication, whatever, but she's been slowly slipping a little bit since then. But I feel like that the nutraceuticals I'm doing, plus we're doing some hyperbaric chamber. We did a little bit of that. We didn't complete it, which is not good. But I feel like, at some point you don't know how much good it's doing. You just don't know how much you're slowing the progression.
Right.
So, but that's that between those two things. And then I was working, my last clinic I worked in was at the homeless clinic downtown. And some of the nurse practitioners, well, one of the nurse practitioners there knew Ed at Nurrition World. And she said, you guys sound alike, you talk alike, you got the same philosophy, same political, same everything. You should go talk to him. So I went and met with Ed, and within 5 minutes of our first discussion together, he was like, would you like to come work here?
Y'all had
Wow.
a secret handshake, didn't you? Within 5 minutes, there was a secret handshake being developed.
And so the rest of it's been, I mean, it's gone about as good as it can go so far.
Good.
That's awesome.
And I tell people all the time, I feel like I make more of a difference in a couple of hours working over there than I did in my years of working at the health department.
Yeah.
And, you know, of course, my years at Erlanger, I wouldn't trade those years for anything. I had a lot of patients that were like family, and so that was valuable. But anyway, that's me. What next?
yeah. So you've been at Nurrition World for how long now?
Went full time in November.
Okay, awesome.
So and what I found out working there was so much I didn't know.
Yeah.
I mean, it's unbelievable
Like
how much I didn't know.
Like drinking out of a fire hydrant, right?
It's-
You just learn something new every day.
Every day, and I
Yeah.
love it. It's just it's like learning all over again, and it's actually finding stuff that you can feel good about.
Absolutely.
Treating people with.
So your passion really came from your original roots of the blood pressure clinic, right? And the hypertension clinic, working with patients with heart disease, which is so important now because it is the leading cause of death in men and women, cardiovascular disease. So for the purpose of today, we're really going to dive into that a little bit about blood pressure treatments that are available, maybe how to minimize those, look at the root issues, some of the polypharmacy that exists where we see lots of different medications used that could cause interactions. And I think you deal with that some up at Nurrition World as well, with working with patients and looking at their med list and that sort of thing.
Yep. Yeah, when I first started taking on clients, doing consultations, I figured I'd be mostly getting people off proton pump inhibitors that they don't need to be on long term, getting them off the statin medications. Different people have different opinions on those, but if you listen to any of my podcast or anything I've been on, you know that I'm not a big fan of them. I don't have as big of an issue with blood pressure medications, only because I don't feel like they're necessarily the solution. They can help with some of the problem, and especially if you're not willing to change your lifestyle. If you're not willing to change how you're eating, your nutrition, you're not willing to exercise, you're not willing to take supplements that may help, if you're not willing to do any of that, blood pressure medications all the way, just because it's better to have something than nothing, assuming you're not doing too much. And that's kind of what brought me here today, was to talk about the elderly patients that are getting too much. They're getting overtreated. And so when I was asked to come talk to y'all on y'all's podcast, they said, what do you want to talk about? And then actually it came down to like, please give me your topic within the next 15 minutes. And I happened to be reading an article where they were doing a study.
Yeah.
Thanks, Ed Jones.
Yeah, right.
Yeah. They were doing a study with in an elderly home where they had reduced the amount of blood pressure medications they were on by 30% and wanted to see what the results of that would be. And what they found was that not only did these patients not end up with any more cardiovascular events or strokes or complications of high blood pressure, not only did they not have the problems, but they actually had the benefit of not having falls, not having hip, breaking their, fracturing their hips, and just the dizziness and the lightheadedness and all the things that can come from. And not only that, the lower your blood pressure goes, the actually more you're putting at risk for cardiovascular problems. So most people don't realize that. They call it the J curve. And so if you think about a graph and you think about over here, you're looking at the risk, the risk going down or up on that. Then you look at the horizontal part of the graph where you go down in your blood pressure and your diastolic. So initially, you got that J, you got the drop. As your blood pressure goes down, you're getting that drop in the risk. But then all of a sudden, as you keep going down, it comes back up like a J, and that's where that J comes in. You're actually increasing your risk of having cardiovascular events and kidney disease and other problems. So you don't want to be going too low. So a lot of people are like, well, what is the magic number? And boy, I don't think we still quite know. I've got my feelings on it. I know that when I first got out of pharmacy school, we first started working, you wanted people to be below 140 over 90. It was pretty simple, 140 over 90. And then, then they started saying, well, in this group of people, diabetes, let's get them below 130 over 80. And then now I'm hearing like 120s
120 over 80 is what, yeah.
And me personally, I kind of, there's a Jack Wolfson is a cardiologist out of Arizona. It's called the Natural Heart Doctor. And a lot of my philosophy in treating blood pressure correlates with his. And but there's a Dr. Brownstein that's been on a podcast with Ed before, who talks about 90 plus your age, and within reason, of course. So in other words, you're 20 years old, 90 plus 20, having a blood pressure around 110 is probably where you need to be, and it's probably a good number. You start seeing 130s and stuff, and you're 20, maybe that's not good. But then you're 50, then all of a sudden you're saying 140 over 90. Hey, that's really, even though some people would say you need to be less than that, that's probably not unreasonable. And then, of course, if you're talking about an 80-year-old, I don't think you want to be a systolic of 170.
Right.
But I think basically the older you get, the more leeway you should have there, because we don't have the vascular system that we had when we were young. I mean, everything changes when we get older. The elasticity of our vascular system is just not what it used to be. And if you want to perfuse this blood and get it to the kidneys and get it to the brain and get it to places it needs to go, you don't want to have blood pressure that's too low. It's kind of like a faucet, You definitely don't want it too high. You don't want it, if you're cleaning your car, you don't want to be taking the paint off, the pressure's so high. But you don't want it dripping out either, or just coming out so slow that you can't. So there's a fine line there of blood pressure. And then some people, and the cardiologist out of Arizona, his big thing is that we don't have a deficiency in pharmaceuticals. We have a blood pressure problem that has a cause. The key is, what's the cause? Agreed. And say his degree now, his wife said he was a medical doctor, a cardiologist, and his wife said, you're going to have a DC degree now. And she was like, you want me to get a doctor of chiropractic? He said, no, you're going to be a doctor of cause. Figure out the cause and solve the problem. And that's what I kind of see my role here is I want to find causes and then find the best solutions, which, of course, most of the solutions come back to the same thing, is getting rid of the problem, the toxicity, getting rid of the inflammation, because the bad stuff causes oxidative stress. Oxidative stress leads to inflammation, which leads to every disease out there. So if we can prevent that, we can prevent. So he doesn't want to go so much after blood pressure as going after the cause, and also trying to prevent the diseases that come along with high blood pressure.
Correct.
And so those diseases that come along with high blood pressures, it's usually not isolated. Sometimes it is isolated to just high blood pressure, and sometimes maybe that's the first symptom or whatever. But it's usually coming back to we put on too much weight, or we're not exercising, or we're oxidatively stressed and we're starting to be hyperinsulinemic. We got too much insulin production.
Yeah.
A lot of people think that blood sugar is the problem, and it is a problem. If your blood's too high, it's a problem. It's hard on your kidneys, hard on your heart, hard on your eyes and brain. It's hard on all that, just like high blood pressure is. But it's also that the insulin, as I was saying, is also damaging to the body. It does all kinds of damage that people don't even realize. So all those years that you're hyperinsulinemic, that you don't even know you have diabetes, you're looking at that thing going, well, I'm 5'8", on my A1C, so I'm still pre-diabetic, I'm okay. But no, in the meantime, you should have been checking your insulin levels and seeing if they were high. If your insulin levels were high, that would have been the best early predictor that you're heading down the road in the wrong path. And so, but I did a lot of talking there.
Both of us are sitting here with our continuous glucose monitors on.
That's right.
Y'all do?
Yeah.
We do.
Oh.
We both have them on right now.
Well, y'all, neither one of y'all fit the profile of.
It's more for information purposes.
Yeah, absolutely.
Figure out what spikes you and what doesn't.
We're giant
But
nerds.
if you got a good functioning pancreas, then any kind of surge in carbohydrates and glucose going in the body, your insulin, your pancreas is going to take care of that.
Take care of it.
But it can tell you though if you're having some early. I mean, it's valuable information in people who are already metabolically challenged. Now, I just not sure how much good information it gives you if you're metabolically healthy, which maybe y'all aren't, but you look at metabolically healthy. Okay.
For me, it is strictly to see like what spikes it more than others. Like, because I do eat pretty healthy. What spikes it more than others.
And when you say spike, I mean, because if you got a good functioning pancreas and everything's working right,
it's coming down to.
Yeah, if everything's working right, you should never go above 126. Yeah.
Right.
So if you're going above 126.
I will say this about that. There are things that send it above 126.
Yes, there are. Yes, there are.
That's interesting.
There are things that right now for me, it's white potatoes will send it above 126.
Because you do know that's
I haven't done pasta yet.
The old diagnostic testing for diabetes used to be you give a big dose of glucose.
Give a mouse a cookie.
Yeah.
Big dose of glucose. And if it goes above 126...
Well, 126 would be fasting, right? Above 126 fasting.
But you still do you're right.
Yeah.
And you're right. I'm sorry.
My fasting is like the mid 80s.
Yeah.
So I'm not terrible.
It's interesting though, and I think for me too, it really is just information, just to see what foods actually spike my glucose, and then how long it stays elevated is important to me. It also helps my habits change. I know that sounds strange, but for me to not snack necessarily, not grab those highly processed foods, to stick to a whole foods diet like you're talking about, the fruits, vegetables, lean meats, it really does change my behavior. So for me, it's very powerful. If I see that number go up, I'm like, nope, not going to eat that.
Seeing is
it is a great tool. I just wish, and it's getting better. And are actually at this very moment in time, I don't know where we stand. Last I'd heard was that we weren't going to be required to have a prescription for it anymore, but are we there yet?
Not there yet.
I think there are some online type companies like NutriSense, I believe is the name, or I can't remember the actual name of it, but they're much more costly. So if you have a prescription, you can go through your pharmacy and get it through it. You can pay cash for it and get it.
Well, last time I ran the last diabetes clinic I had was at the homeless clinic, and we weren't able to get continuous glucose monitoring.
Yeah.
And then the working poor clinic I worked at before at Dotson Avenue, I just never, people couldn't afford it, or their insurance wasn't paying for it. And we just had, so I had just to work with my good old fashioned A1Cs every 3 to 6 months.
Which is great, I mean, you work with what you have for sure. And I love what you talk about looking for the root cause, but I think sometimes people don't understand even, and I think it's important to highlight, you have to kind of know where you are, which is why, like, for instance, Mandy and I love these little glucose monitors for a time frame, for a short time frame, just so we have that awareness. I think the same holds true for blood pressure. So, Curt, you mentioned that in that original clinic you were in, they had the home monitoring system, which I think is excellent that someone could.
1993.
That's a long time ago, but I remember 93. That was the blizzard, the year of the blizzard.
Yes, it was. We don't talk about that.
Yeah. But what would you recommend for people who are listening today? What's the best way to know what is your blood pressure? Because, oftentimes you rush into a doctor's office, you may have had to wait for 30 minutes, your anxiety is high. Many people have white coat syndrome, or you've rushed into Walgreens, you're using a cuff that doesn't fit your arm. You may have just had lunch or a cup of coffee. So tell us, what is the best way to know? What is your blood pressure?
Well, taking a blood pressure, I mean, first of all, if you're using a home machine, getting a brachial reading, so across your artery right here
which would be like the bicep arm, correct,
is going to be your best way to go. It's got to be a cuff that fits properly, not too tight, not too loose, because you can get big fluctuations just not having those right. People should ideally, I mean, I used to see this all the time at the clinics I'd work in. I would try to educate the nurse techs and people that were taking the bus. I try to educate them. I think so people get in a hurry. They got so many patients they got to see and get in and out that they just start cutting corners a little bit. But ideally, you get them in there, you sit them down for 5 minutes. They have time to relax. Both feet are on the floor, not crossed. Their back's being supported. The arm is being supported at the level of the heart. These are all proper ways to take a blood pressure. Not chewing gum, not talking. I've seen a violation of all this in people before. I've seen somebody just sitting there, leaning forward, legs crossed, not taking the blood pressure with a cuff that was not fitting
Arm is
properly.
bent,
They're still wearing, you know, and you don't have to absolutely have your shirt off or whatever, but sometimes it can make a difference. Sometimes it doesn't.
More of checking a box, less of getting an accurate reading. Is that what you're saying?
Yeah. Where they just, and then once numbers were out of control, I used to, this is the medical world for you. I used to laugh at this. Somebody come in, blood pressure would be 180 over whatever. So we'd go and get them a clonidine pill, 0.1 milligrams. Here, take this. They take the clonidine pill. 30 minutes later, they take the blood pressure, and they've come down. They're one, whatever, good enough, 140 over 88 or something. It's good enough. So they see the doctor or whatever. And then these people are going home, and what does clonidine do? It lowers your blood pressure for about 6 to 8 hours. It can actually cause rebound hypertension. So they're going home and their blood pressure is probably spiking back up to 200.
Oh, my.
What do we do here? We not only put a Band-Aid on it, but they're just going to go home and it's going to be ripped off and just cause. I used to hate that whole thought process of giving a clonidine just to make it look good while they're in the office. That's all it's doing.
So it's not your problem anymore, I guess.
Yeah.
You know?
Anyway, I never liked clonidine to begin with, but
so what would you recommend then? Do you like the home? I mean, would you recommend? I know what we have always, or we used to recommend. I worked in a dialysis clinic, so we saw the end stage of high blood pressure that was left untreated for years, and diabetes. And so what would you recommend for somebody who is monitoring their blood pressure at home? How often would they want to take it? Keep a diary?
You get different opinions on that. I mean, for me, I like to, sometimes more information is better. And so for treatment purposes and for monitoring purposes, sometimes more is better, kind of like the continuous glucose monitoring is better than just checking a finger stick a couple times a day. However, if it's the patient you're talking about, there tends to also be this whole anxiety. Sometimes it's better just to chill and check it once a day and let some, time pass instead of worrying about it and checking it 12 times a day. It's probably not a good thing. Now, if you're trying to see how a new supplement's working or a new medication's working, then getting more readings can be good. Is it waning towards the end of the 24-hour period? So you check it in the morning before you take your blood pressure medicine. Are you more elevated so you're not getting good 24-hour coverage from that, either medicine or supplement? So that kind of information's good, but I think you've got to be careful you don't overdo how much you're checking it.
Correct, yeah. So you're not creating anxiety.
I know I didn't answer the question.
No, that's good. Good information. It's good things for us to think about for the general population when you're trying to understand, where am I? Because it's often been called the silent killer to have that elevated blood pressure for years. And so for patients or the population to understand, how do I check it? How do I have a real number where I've not just walked into the doctor's office, been high anxiety because I was just in traffic or had to wait 30 minutes in the lobby, and then you're told or diagnosed with elevated blood pressure. Right. So keeping that journal at home, putting your activities down around that reading. Would you also recommend that as well? Well,
just something popped in my head that I want to make sure I get out, and that is, what is the problem with what you're saying here of people coming in and what their blood pressure is right then and what we do? So you get all kinds of problems. One is, was their blood pressure, is it white coat hypertension? Are they, was everything taken properly, done properly with the checking of the blood pressure? So what you end up seeing is, I know that going back to my early days, I would see these people on polypharmacy and their blood pressure would be high in the clinic. And I'm sure that, I don't know why they never thought of this, but the way it worked at Grady was that you saw the doctor, you got a 30-month supply of medication, and then they'd have you come back, they'd have you come back at like 31 to 33 days or whatever. So these people were coming back, they've been out of their blood pressure med for a couple of days. They weren't asked, did you take your blood pressure medication today? Which sounds like a simple enough question, and you should ask it, but they weren't. And so their blood pressures were high, and so they were like, okay, last time we had you on, we had you on, back in those days, we had you on nifedipine 30, we're going to go to nifedipine 60. Well, no, you don't need to go up on their blood pressure. So I was catching all that and saying, we don't need to go up on their doses here because they're not taking it.
Right.
But back to what I was mentioning, which was, so you've got all kinds of issues going on here. You've got them assuming that their blood pressure is higher, and so they're adding on more medication. And so what you end up with is polypharmacy, and you end up with people on too much medication. And the older we get, of course, you're starting to get to where if you're not having perfusion to the kidneys and stuff, then you can actually end up with kidney damage. So you end up with a lightheadedness and the increased risk of strokes and things. So there's a balance there. And what I'm seeing so far is that we overtreat. And what that study I mentioned is saying is that, we are overtreating and we can afford to scale back. And so there's a lot of confusion there. And some of the polypharmacy comes from, when I started running my hypertensive clinic, there would be people on one medication by itself. And you'd think that, you just want to stick with one medication. But the truth is that we know that the cause is, the disease is the cause of what you are doing to yourself. However, you have this is a, quote, blood pressure disease. And so sometimes your body thinks that new blood pressure is normal. So it may be running around at 150 over 100, but your body kind of thinks that's normal. And all of a sudden you throw in a blood pressure medication, like a calcium channel blocker, your blood pressure comes down to 130 something over 80 something, but your body says, my blood pressure just went down.
Alert.
It starts kicking in. Mostly the time it goes to the kidneys and says, do something about this. And then you end up, it brings the blood pressure back up. Now, the net effect is your blood pressure goes down, or else we wouldn't use blood pressure medications, or at least we wouldn't use them without using something else. So that's where it was called dual therapy came in, that using two different medications that have different mechanism of actions can actually have more of a synergistic effect instead of an additive effect, because one's compensating when the body's trying to compensate for that drop in blood pressure, you can actually block that with the other medication.
Gotcha.
So then you end up with even more blood pressure. So it's better. The concept used to be you'd want to stick with lower doses of two different types of classes of medications instead of just keeping up in the dose and trying to get more and more effect. Because most medications in the world have what they call a flat dose response. As you go up on the dose, you flatten the response. It doesn't keep going up exponentially. It flattens out. So the more, but the side effects though usually are exponential. The more you add the dose, like amlodipine 5 milligrams usually does a great job at lowering blood pressure. And the minute you go to 10, all of a sudden those people are coming back. They got swollen ankles.
Oh, wow. They've
got headaches, and they're just getting all kinds of side effects with it. So I like sticking with low doses if I'm going to use a pharmaceutical. I'm kind of back in my mindset of when I ran my clinics.
Sure.
Now I'm more in the mindset of get rid of the problem, and we won't need these.
So let's talk about that. What do you see as the primary problems? I know you mentioned weight with obesity. What are some of the other primary problems that would lead to elevated blood pressure?
This the same cardiovascular. No.
Cardiometabolic?
Metabolic.
I'm going to guess.
I was going to say metabolic.
Right.
It's the metabolic diseases. It's the
insulin resistance.
It's all these things that are causing when you do oxidative stress in the body, you're causing inflammation. Then you end up your vascular system just can't. You do damage to the lining of your arteries, and you end up not being able to. So you end up with more vasoconstriction, which is what's causing your blood pressure to go up. So blood pressure can be, it's heart rate times peripheral resistance times stroke volume. That's kind
sounds very good to me. Yes.
Anyway, that's where you come up with blood pressure, is that formula there. And so if any one of those gets off for some reason, but it's usually, a metabolic disease in conjunction with that's causing the oxidative stress, the inflammation, the damage to the lining of the arteries, the vasoconstriction, and then you're just trying to find ways to relax the blood vessels to get them to open up. So usually you're doing that with blood pressure medications, but lo and behold, we can do that with natural things too, supplements.
So what do you see natural supplement wise? What have you used that you've seen good results from?
Well, at Nurrition World, we have what we call our Core 4, and the Core 4 is a quality multivitamin. That's good, not necessarily for blood pressure, but that's good to be on. But your omega-3s are going to have a positive effect in a number of ways, inflammation and what have you, but it's also been shown to lower blood pressure. Magnesium, so if you get a vitamin D with K, is going to help. So 3 of the 4 Core 4s actually help improve blood pressure. So magnesium being a big one. And then you start looking at vitamin C is beneficial.
Okay.
CoQ10, aged garlic, beetroots, anything that can increase nitric oxide in the body, like L-arginine, can cause you nitric oxide and vasodilation. And once again, I'm mentioning the medications, and I mentioned this, but this don't forget that we don't want to put a Band-Aid on it. We want to help. And these things are good and good for you, and you want to be on C, and you want to be on magnesium, you want to be on all these things. But let's try to, if we can, let's try to minimize even how many of those we're on.
Yeah.
Right.
Even though some of the side benefits of these things, you kind of sometimes want to take them, you know.
Sure.
Olive leaf extract, and there's just so many of them that I recommend. Hibiscus is a good one. It kind of works like a natural.
Plus, it's pretty.
Anything that calms you down, L-theanine, and so these are all the things that I've been recommending and trying to get people to taper off their pharmaceutical. Of course, I do this in conjunction. I want them to work in conjunction with their medical doctor.
Sure.
And, I want them to be a part of the process. I tell them anything I provide to you here, anything I tell you, I usually give them a nice handout. And I say, bring this back to your physician, run it by them, see what they say. If they're resistant to you, ultimately you make the decision. And, you make up your mind what you want to be on and what you don't want to be on. Right. But I don't want to work against them. I don't want to always act like I'm perfect and know everything in the world. But I feel like that this holistic approach and integrative, I truly believe it's actually the best way to go for outcomes purposes. Because with the pharmaceuticals, once again, the early data that was done with these things, I was a part of a big time study at Grady where we looked at all the major classes of blood pressure medications and we looked at outcomes. And they, some were better than others, but calcium channel blockers and ACE inhibitors had good outcomes and it looked good. But once again, we always got to keep in mind how numbers can be manipulated, how statistics can be manipulated. Just because something lowered something, how much did it lower it? I'd love to compare these things, and it's actually been done. Paleo diets and things like that have been compared and shown to be better outcomes because you're getting rid of the problem. And so pharmaceuticals, while they're putting a Band-Aid on it, it shouldn't be the goal to just keep adding on more medications. It should be the goal to be able to get you off of them.
Right.
And if you need them, temporarily, it's like I wrote an article last month on the blog, talking about using Ozempic and things. I used to use it for obese women or men, but usually it was women, obese, whose A1Cs were above 10, and they needed something to kickstart them.
Yeah.
And the way I did it, though, was I probably should have wrote papers on it. Or I would tell the pharmaceutical companies, the reps that would come in, and I'd tell them the way I did it. And I'd say, your beginning dose, I would start with half of that.
Yes.
And
that micro dose.
And I would
can
do
be
that.
So powerful.
As long as you can.
There used to be a little pin. You'd click it, so many clicks. And so I would go half the number of clicks. And then each week they might go up by a click or two. And it was just they used to call it go slow. Start low and go slow is what we used to call it. I had a lot of success with people tolerating Ozempic versus what you hear nowadays. Eventually they would have problems. And don't get me wrong, I had people that came back, and I'd say, how'd you do? Well, you didn't hear, I was in the hospital for 4 days with pancreatitis.
Oh, wow.
It's like, I'm so sorry.
Oh, no, yeah.
Because you do feel a little responsibility when you put somebody on something and something bad happens.
Sure.
But anyway, what else?
Well, how can people find you? If they want to come see you, they have, let's just say, I have a diagnosis of high blood pressure. I'm on 2 or 3 medications. I want to look at this with someone that can help me look at this objectively, look at my lifestyle, help me identify the root cause. Could I minimize my meds, in correlation with my doctor? How can they find you? Tell us how that process works.
You can come to Nurrition World, and I'm there most of the time unless I'm doing a consult or a podcast.
Lest we take you away from your drive.
Right.
Understood. We're so sorry, but not sorry.
So in there, we could talk and have a discussion. There are times when I just say, you're on 2, 3 medications. This is pretty simple. We don't need a long, drawn-out consult that's $95 an hour.
Right.
I can just... But the people that are on like 7, 8, 12, 15 medications, and that usually requires a little more preparing on my part, a little more time of meeting and deciding what's best for them. And so those are the best patients for me. But to get in touch with me, you can go to Curt, C-U-R-T, at nutritionw.com, send me an email, or you can go to the website, Nurrition World's website, and there's a place for consultations on there, and we've got different health coaches, and depending on what you need, if you're having gut issues, you're going to go to one Amber probably. If you got nutrition and weight and things like that, you're probably going to go to Adam. Ed's always good for everything, and he's a DC.
One-stop shop.
He's
right?
multifunctional.
He's a DC. He's a doctor of cause, so he'll
the
figure
OG,
it out.
yeah, the original.
He's a goat.
Yeah.
I think I'm gonna go to DC or maybe DT, a doctor of therapeutics. That
There you
sounds
go.
There you
better.
go.
But, actually, I got a PharmD. I don't need to come up with it.
No, you don't. Well, what I would say is that you are a true bridge between traditional medicine and preventive medicine, functional medicine, however you want to call it. And we need more people like you out there that have the knowledge, have the certification, have the experience, and have gained wisdom in that can then bridge this gap that we have between pharmaceuticals, non-pharmaceuticals, lifestyle. So thank you for joining us today. You've brought a lot for us to consider, and I think for people out there, it brings hope.
Uh-oh.
One more thought.
But wait, there's more.
I want to bring out something that maybe people have never heard. I never knew this before I started working at Nurrition World and started looking at it. And I'm getting more and more amazed every day at how much probiotics, what they're good for. They actually can, by taking probiotics, you can end up improving your endothelial lining. You can end up with less. Anyway, it can be good for blood pressure.
Oh.
And then we know it's already good for your gut lining, which there's a gut-brain connection. So it's good for the brain. It's good for the skin. I mean, probiotics are starting to be more and more, the more we learn about them, the more we like them.
Yeah.
And the more mind-boggling it is to understand that we have 350 trillion viruses in our body and 300-something billion bacteria in our body, that all these are playing a role in how we're functioning. And so having the good ones in there, of course, is the way to go.
So are you saying there could be a core 5, maybe?
That's what that sounded like to me.
Well, I have what I call...
Let's pitch it. You want to?
Well, maybe I'll have you back someday. But
You heard it here.
I have
There's
what I
gonna be a
call...
core
Well, I have what I
5.
call the core 4, and I have what I call Dr. Dearing's plus 4 more.
Oh, well, you didn't tell us that.
Yeah.
Please tell.
Well, the 4 more is my favorite for everything. Even blood pressure is curcumin.
Yes.
I mean, it's the strongest anti-inflammatory in nature. So it's literally good for everything. I mean, it boggles the mind how many things, disease states it's good for. I mean, Alzheimer's and depression and blood pressure and even reflux. It's just irritable bowel syndrome, knee pain. You just name it. It's good for it. Then there's quercetin, and I don't know how many people know about quercetin, but it's good for antioxidant, good for blood pressure, good for the prostate, good for fighting off cancer cells. I take it every day for allergies. So that's one. Then there's N-acetylcysteine, NAC, NAC, whatever you want to call it. That's one of mine. My other one is I almost don't even want to mention it because it.
Oh, no, you have to.
You have to, absolutely.
Because he's going to talk.
Well, one is I sort of do a dichotomy. For certain patients, I go with French grapeseed extract, which is good for blood pressure, good for heart health, good for fighting cancer. Good. But the other one's one I'm hesitant to mention because it's got bad connotations.
I'm
just going to say in the pharmaceutical world.
Do it. Go for it.
In the
Rip it off.
pharmaceutical world, in 1,000 milligrams plus, you would use it for schizophrenia.
Ooh.
But in the nutraceutical world, you use it in microdoses at 5 to 15 milligrams, and it's lithium.
Oh.
So lithium is a trace element. There's a Dr. Niels out of Germany that's writing a book on it. And it just calms the brain. It relaxes you. It's good for Alzheimer's. It's been shown, this is kind of, I looked it up to validate this, and it's true that there was communities where it was put into the water.
Yeah.
And in those communities, they studied it. The crime rate went down. The homicide rates went down. So
Wow.
Yeah, so crime and suicide rates went down.
Wow.
That's interesting.
So when I start talking to people about it, I'd say the sales of lithium since I've been working there have gone up probably 1,000%. And I mean, they've actually had to go in and order a lot more.
Here's my fear. I would go in and get it, and I'd be like, I think I just need like the smallest dose. And they're like, oh, precious. No, you're going to have a whole lot more than that.
That's another podcast.
Pretty sure it'd be like, oh, a little bit. You're going to have a whole lot more than that.
Well, I know I appreciate y'all having me in. I
Yes.
feel like there was so much about the blood pressure stuff that I didn't cover, but I think we got the gist of it.
I think so. And
It
I think
sounds like a
people-
Part B.
Yeah. Yeah.
Or
There you
Part
go.
B. I've had some Part Bs with Ed with his part because I'll get done and I look back over my notes and I say, man, I didn't talk about half of what I was planning on talking about.
Well, the good point is that people know where to find you if they're having an issue with this or anything that they just want your input on.
And hopefully I drove home the solution.
I think so. Doctor of cause.
Yes.
Or
Eat
theory.
better.
Root cause.
Eat
Root cause.
better.
Which is, music to our ears at Optimize You. So thank you, Curt, for joining us.
Well, thank
and
you for
until
having me.
next time or till Part B, right, Mandy?
Right? All the above. Yeah. Thanks, friends.
Thanks, guys.